So it's a pleasure to be here and discuss how technology is solving real-world challenges. First of all, ischemic heart disease is a global real health problem. We all know this, especially in this venue. And second, according to the new recommendations, every patient with a pretest probability of coronary disease between 5 and 50% has a class 1 indications for CCTA. And actually, when we look at the guidelines, nearly all patients with chest pain without obvious acute coronary syndrome qualify for this bracket between 5 and 50%. Benefits of CCTA include that this is a non-invasive test. It is maybe performed on outpatient basis, takes just like 15-20 minutes, safe, and above all, it's accurate, so provides a good, reliable clinical information. And that's why CCTA is skyrocketing as the leading test for chest pain. And excluding coronary artery disease, the binary information, whether the patient is healthy or not healthy, it was just the beginning of CCTA a couple of years ago. Currently, and actually soon, or maybe even currently, CCTA becomes, or in some places already is, the central tool for managing and diagnosis and treatment of coronary disease. So coronary plaques mean risk. CCTA benefit include that it can non-invasively show coronary atherosclerosis, which is not even visible, as we can see on invasive angiography. Here we can see an example how massive atherosclerosis can be concealed even for invasive coronary angiography. Here we can see the IVUS representation of the left main plaque. Currently, there is no better method for detecting high-risk plaques than CCTA, which embraces all major vessels in a non-invasive test. And the diagnosis is based on recognition of the presence of positive remodeling, small calcifications, low attenuation plaque. So we have kind of histopathological diagnosis based on non-invasive test. An exemplary patient with both longitudinal and IVUS-like cross-sections, we can appreciate positive remodeling and low attenuation plaque components. So those are images that future doctors learn at their histology lectures with non-invasive tests. So for these reasons, CCTA helps to qualify for medical treatment. For the first time, a scientific statement from American Heart Association, just like two weeks, maybe 3 weeks ago, defines non-obstructive coronary artery disease, which is NOCA. Please remember this abbreviation like INOCA or ANOCA, so it's NOCA. And based on CCTA, we can evaluate the high risk, which would be or is equivalent of risk like for the secondary prevention, but in those patients who have no had any previous cardiac events. So the next topic, accordingly, European cardiologists are not far behind American ones. Very recent publication from ESC, a new statement which validates CCTA as a key diagnostic modality for a step further monitoring of treatment of coronary artery disease. This allows individually tailored therapeutic approach for especially high-risk patients, especially the younger patients. Here we can see a quite, I'd say, spectacular atherosclerosis regression case from our routine clinical practice. We can appreciate not just regression of the plaque, but also enlargement of the lumen associating the regression of the plaque. Those images are, we see, the more examinations we make, the more those images we see. But also, of course, we see the progression of atherosclerosis in those patients who do not receive appropriate treatment. The next dimension of CCTA use for clinical purposes, we also observe a growing role of CCTA in the process of qualification for and planning of interventional treatment of coronary disease. As usually for anatomic methods, borderline stenosis that require functional confirmation remain the Achilles heel, so we have to manage somehow the many patients that come out from CCTA examinations with intermediate lesions. Why functional information matters? First of all, ischemic myocardial volume defines which patients will derive outcome benefits from revascularization. And today, it is quite impossible to discuss PCI planning based on CCTA without accounting for FFRCT. The analysis is based on the routine data set of an ordinary CCTA, but it must be stressed that the better the data quality, the more accurate the CT-FFR result will be. So importantly, the method is already recommended by American guidelines, and recently European guidelines joined in the recommendations of this method for examination of intermediate stenosis diagnosed on CCTA. CCTA helps to plan the revascularization strategies. As we showed, it predicts bypass graft patency in a long-term follow-up. As well, it predicts physiological outcome of virtual stenting. Here we can see an example of a patient with diffuse atherosclerosis. On invasive angio, we wouldn't be able to appreciate the atherosclerotic burden within the reference areas, but with CCTA we can see the extent of atherosclerosis within the whole coronary artery. And as we can see, potential stenting of such a patient would not provide optimal physiological outcome. Following stenting, still FFRs would be kind of like on the verge of ischemic, so maybe those patients maybe could benefit from CABG and not PCI. So all this allows to appropriately plan PCI, prepare equipment, and also helps to in peri-procedural navigation. Actually, CCTA-based tool currently may replace old-fashioned invasive pre-interventional patient evaluation. And we must say that technologically high-quality CCTA plus CCTA-based tools are currently able to eradicate invasive diagnostics of coronary artery disease. So we have, of course, the problem, which is lack of full integration and optimal use of those CCTA imaging data by cardiologists in their everyday practice. And let's see how HemoLens solutions may help you to make decisions helping in patient management in your clinical practice. Thank you very much.
Okay, thank you, Professor Kruk. As you could see, the CCTA gives a lot of information, and at HemoLens, we are developing a CardioLens platform that has an aim to make the CCTA information actionable to improve cardiovascular care in all of the steps in the patient pathway, which is from screening and diagnostics through treatment planning and even up to interventional planning. As there is a lot of information in CCTA, it doesn't come without its challenges to get this information out of. And as you can see on the slide, I've put some problems that physicians face while trying to work with CCTA. And together with clinicians like Professor Kruk, we are working to take the full advantage and overcome those challenges in the clinical practice. And our platform, CardioLens, is a response to patient and doctor concerns, and it is made of 4 products. First of them is CardioLens Viewer. It is a, let's say, screening tool that is taking the CCTA and giving back the three-dimensional reconstruction of coronary arteries, which allows for doctors to work with minimum training. It gives the automatic stenosis finding and plaque distribution at the first site. So we already have this product implemented in some real-life tests, and we got some very nice reviews and feedback from clinicians. One of them is that CardioLens is giving one of the best automatic coronary reconstructions on the market, that it is valuable for the clinical workflow, and that it significantly reduces the manual work. So once there is the reconstruction and physicians finds the stenosis, the next step is to calculate the FFRCT, and this is the next step in our platform called CardioLens FFRCT Pro. Here, automatically, we calculate the values of the FFR in the whole coronary tree. We use the patented technology to because we are using a second signal, not only CCTA, but also CNBP, which is continuous non-invasive blood pressure measurements. We have a patented technology to use this signal to compute the boundary conditions for the simulation of the blood flow through the coronary arteries. And this is something that gives us better, more patient-specific results. And the physician is able to read the FFR results through this 3D reconstruction colored by the FFR values. Moreover, we have a pulled back like graph of the values on the coronary artery center lines. This product is not yet available on the market, but we have very nice results for our first internal tests showing that we are able to have a higher accuracy in the so-called gray zone, so in the most important zone or most important place for the physicians. This will soon probably, hopefully, be published article. We have this patented technology that is giving us a freedom to operate in those countries, as you can see in blue. So we have very nice freedom to operate. And we have 2 ongoing trials. One is in 8 clinical sites in Poland, which we have finished in recruitment. Hopefully we will get results by the end of the year. And the second trial that is ongoing in 3 clinical sites in the Netherlands. So this product is also well established, but not yet available. Next step in our platform will be CardioLens Plaque, which we plan for the Q1 in 2026. And this will give physicians the amount of the plaque and stratification of the plaque in the coronary arteries, with the stratification to calcified, non-calcified, low attenuation plaque, with statistics for the whole patient, the volume of the different types of plaque for the whole patient, and divided into 3 main arteries. We have pending clinical validation study. As I said, this should be finished by the Q1 in 2026. And the last step in the CardioLens platform will be CardioLens Strategists, which will be a tool for CT-based PCI. This will be a tool for interventional cardiologists that will allow to get familiar with patients' coronary arteries, with plaque, with the stenosis of the patients before entering the cath lab. So cardiologists will be able to find or check what stent will be needed, what tools would be needed during the procedure, and have this information before entering the cath lab. Here you can see the whole workflow of our platform. So we have a patient. We can use the CCTA only for 3 products on our platform. The FFRCT Pro needs an additional signal. This is CNBP. This is a signal taken from patient's finger. It's a 3 to 5 minute measurement of the pressure. And as you can see, physician is able to use all of those products and make a clinical decision what is the best way to treat the patient. As I said, we have a strong connection with clinicians. They are our advisors on how to proceed, what are the needs of their society, and how we should proceed with our products. We have here Professor Cezary Kępka and Professor Mariusz Kruk with us. We have a strong team back in Poland because the company is based in Wrocław, but we also have a presence in the Netherlands and in UK. Thank you, and if you have any questions, please visit us on the booth E2, and I think we have also some time here and now to answer some questions. Thank you. If there are no questions, then thank you.